Perfect. So the first part of this journal club is to, first of all, introduce the idea of what we're trying to do here, how we're trying to approach it, and how we're using evidence-based medicine principles to be able to find a clinical question that's relevant to us from our clinical practice, generate a clinical scenario which somebody presents, and then we find a way to be able to ask a focus question that comes up from our clinical scenario, search and select using a systematic way, and then we will use the rest of our time to go individually or within our groups to be able to assess the paper that we've identified through our selection process. We specifically look at the validity and the results of the study, and this takes about 30 minutes, and then we get back together to discuss what we thought of the paper and whether or not this would change our practice relating to the clinical scenario that we have. And then in the final 5 minutes, we'll review what we've done in this session, try to come up with a plan for the next session, and would, as always, love your feedback. So just a quick summary of what we are doing in these journal club sessions. What we do is we get a nominated hospital or a group from a nominated hospital to be able to ask a clinical question from pediatrics, and then find a systematic way to search this, and then generate a one paper that answers this particular question that we as a group can then appraise and see if that will help us understand that topic and also change our practice. Then what we'll do is, once we've appraised it, we will then poll your views and see if we can make any changes to our practice, and also move on to see what further evidence we can find. And the idea here is to be able to actually use our experience from clinical practice and apply evidence-based medicine to what we see in clinical practice, and practice it together to be able to see if we can get further answers. So just briefly, what evidence-based medicine principles are. Obviously the evidence is important, so the papers that we're appraising, but it's in combination with the patient that we have in front of us, the environment and the expertise that we have, to then be able to integrate it together and generate a conclusion from what we are seeing within the evidence. So what we're going to do today, as we've mentioned, is to Harris is going to first of all set up a clinical scenario, and then we're going to generate a focus question from this, and they'll talk through how they searched through the evidence to be able to find the evidence that we want to appraise. So this is our nominated team, and then what we're going to do as a group for about 20 minutes is to appraise the evidence and decide whether or not this will change our clinical practice. And the idea is to learn by doing and by example overall. So a brief summary of how we ask our focus questions in these sessions is that we use our PICO format to be able to structure it, and then we find what particular evidence matches exactly that PICO question. So this is a tool that we use, which is useful, but is by no means the only way to be able to ask these questions. And in terms of the evidence, we find the study that's most suitable, which can be different types of studies that we have, and we try to find something that has been well executed so that we can get conclusions out of it. So without further ado, I'm going to get our nominated team from the Royal London to be able to present our case scenario. Harris, are you?
Yep.
Perfect. Will it be you, Harris, today?
Yes. So hi, everyone. Once again, I just decided to show my face briefly. I've got a couple of furry friends around, so if they jump in front of the screen, I'll turn my camera off. So I've met a few of you through the course of the week because it's been the PEM week. So as Daphne said, our department, our pediatric ED unit, decided to look into a clinical question this week, and I was actually working on this with a colleague of mine, Jess Britton George, who is an RChem trainee working in PEM at the moment, and she came up with this question that we decided to look into. Unfortunately, just after she prepared her slides and was ready to present, she has fallen sick. So I'm doing this on behalf of her, this part, and I hope she gets better soon. So she has designed the scenario of an 80-year-old boy, which is based on the real cases we've been seeing in our ED lately, who presented with right iliac fossa pain, initially started centrally and then migrated to the right iliac fossa. When he presented, he had marked rebound tenderness, but he was not peritonitic, and his examination was otherwise unremarkable. He was a stable patient. No fever, but he had been vomiting. Hadn't eaten all day. He was walking doubled over, and he couldn't do the hop test, you know, when we ask them to hop on one leg to assess just a rough test that we do for appendicitis. So obviously in our top of our differentials was acute appendicitis. So we rang the surgeons, who we have local pediatric surgeons at the Royal London, and as usual they asked for some bloods, but they told us that they were likely to be sending him home with a course of antibiotics, as this was the new trust policy. So some of you may have experienced this as well in your departments, but this is something we have practiced more and more during the pandemic, and that's opened up a new window of possibility and clinical questioning for us, really, because as you all know, during the COVID-19 pandemic, we've all tried to minimize the operations we do, the number of children we put under general anesthetics, and particularly the intubations. And that's even for children that were not symptomatic with COVID, because they could potentially be carriers. And obviously we didn't want to be intubating those children and taking them to theatre if we could avoid it. So there was this consensus with the surgical team that we would try to manage as many of them as possible conservatively. So it has become a kind of local guideline during this time to treat them with a course of antibiotics and to follow these patients up as an outpatient. I've been hearing that a lot of hospitals have been doing that, so we thought this would be of interest to many of you. So we thought of looking, has there been any evidence on this? Is it a safe and sustainable course of action? And is this something we can carry on doing after the pandemic is over, or will we see a lot of returning patients potentially with complicated appendices such as perforation? So we've decided to use that to form our picker question. And as always, those of you that have done journal clubs or have been coming to these sessions a lot, you know by now that we frame our questions based on the PICO model. So for the particular clinical question, our population were children with suspected acute appendicitis. And I have to add here that we're looking at uncomplicated appendices and not the ones where we already have a suspicion of perforation or a mass formation, an abscess, or unstable septic kits. Intervention is conservative management or antibiotic management, and the comparison, of course, is our standard care, which is appendectomy operative management. And the outcome is incidence of adverse outcomes, and that can include complications, or it can include need for operation soon afterwards. So we will look into that. So JBG, that's how Jess is known in our department, has made a slide with the hierarchy of evidence, which I'm sure many of you have seen lots of times before. And rightly so, because we are looking at a question of treatment. Ideally, the best level of evidence, just like with many questions, would be a meta-analysis and a systematic review, ideally of randomized controlled trials. And obviously the next best level of evidence would be multi-center as it is. So we weren't sure how much we would find in the form of randomized controlled trials, because as you've seen from previous sessions, sometimes even questions of treatment can be answered by case control studies, for example, observational studies. So we've done our literature search. We started off with PubMed and we chose the clinical queries sub-unit of PubMed because it's a genuine clinical question that can be answered with the routine evidence-based medicine questions. And we decided to start broad initially with our search terms, which is always a good idea. And then if we were getting lots and lots of results, to narrow it down by adding more search terms and play a little bit with our booleans. So to start with, we use the terms appendicitis and conservative. We didn't use children or pediatric because in PubMed you can do that in the filters, as many of you know. And then we used, in clinical queries, it breaks them down into systematic reviews and trials. So the screenshot you can see there is from the systematic review section. We chose as filters last 5 years, and that was based on a rough literature search we had done, and we knew that most of the evidence was from the last 5 years, and sort of to make it more manageable and more relevant to our practice. And then we filtered to children ages 0 to 18. And as I said, this is the section on systematic reviews and meta-analysis. So we didn't get very many results, which meant we didn't need to narrow down. We were good with just the 2 search terms. And the most relevant paper, because some of them, there are meta-analyses that look at complicated appendicitis with perforation or abscess formation. Apparently in some countries, even those cases can be managed conservatively, but that was not our clinical question because that's not something we generally do in our departments. So the most relevant paper was one from the Archives of Disease in Childhood, a 2017 meta-analysis by Kessler et al. I'm going to show you a screenshot a little bit later. And interestingly, going through the similar results suggestions that PubMed brings for you if you click on a paper, we found this other meta-analysis, a Chinese one by Bi et al. From 2019, so much more recent. So that triggered our curiosity really, and we thought, let's see if we weren't sure why our PubMed search didn't yield that, because as I said, we went quite broad. So we moved on to Cochrane. I think next slide is on Cochrane. Yes. As always, and that's how we did.
The board. There is one.
Oh, sorry, someone is okay. Shall I mute everyone? I think you're all muted now.
Yes.
Okay.
Yes.
So we formed our search strategy through the advanced search with them booleans and use some mesh terms, as you can see on the screen. I'm not going to go very much into it, but essentially we use appendicitis, children, conservative or medical or non-operative management or treatment, and we combine them. We didn't get any relevant Cochrane reviews or any relevant systematic reviews, and all of the studies we found had already been yielded from the PubMed search. And we also looked into TRIP database because we like TRIP. And again, we use similar terms. And once again, the most relevant and high level of evidence paper we found was the Kessler, the Archives paper. And once again, interestingly, we didn't get the paper we chose, but it recurrently came up in the suggested publications by PubMed. I suspect it's something to do with how the authors have done their keywords and how they linked it on PubMed, but it's just a good reminder for everyone that when you want to do a thorough literature search, especially when you're working on a systematic review yourself, it's always good practice to look at the references of other papers and look at the suggested similar papers by PubMed, because otherwise we would have missed the most recent meta-analysis. Okay, so And finally, as I've already said, we were in between the two meta-analyses. The fact that one of them was not yielded easily in our search strategy made us a little bit suspicious, and we wanted to make sure it was a good and a valid study. We went through the basics, and actually all of the papers that were included in the previous paper, which is the archives paper that is shown on the left bottom of the screen with its citation, all of the studies included in that one were also included in the newer Chinese one, the B et al., with the addition of 2 or 3 more papers. So we opted for the more recent one that included more papers. People are saying they can't hear us. Okay.
Don't worry, we're managing it.
Yeah, that's fine. I think it's to do with people's bandwidth, as I've learned very well this week. So we settled on that paper. Some of you may have managed to read it in advance from our the timetable. We included a PDF link to that, but we'll go through it together.
I'm going to copy that across now into the chat.
Thanks, Andrew.
And let me know if you can't download it on an NHS computer.
Okay, is everyone muted now? Can I just ask, while Andrew is sharing the paper, which is there now, can I just get a virtual show of hands, maybe by typing yes in the chat box, if other departments have had similar experiences? Have you also had an increased number of patients with suspected appendices being managed conservatively? Yes. Yes. Yeah, great.
Patient or inpatient?
Oh, we are talking about ED presentations, but some of them get.
I mean, managed by discharge on oral antibiotics or keeping in hospital on intravenous.
That's actually a very good point, and we'll come to that during the paper. But yes, please feel free to share if your patients were sent home on orals, or they were admitted for IV antibiotics. That would be interesting. And none of the people that have answered yes, actually, I don't think work in my hospital. So that's interesting. It means that quite a few other hospitals have been doing that. Lots of admissions for observation and no antibiotics. None treated with antibiotics instead of surgery. Discharge on oral with 48-hour review at the Whittington. Thank you, Harry. Thank you, Croydon team. Michelle. Some oral, some admitted on IV. So great. So that just shows that exactly what evidence-based medicine is about, right? That there is some clinical equipoise. We were kind of forced because of the pandemic to adjust and change our practices. But the fact that we are all doing slightly different things shows that there's no consensus. And hopefully that just shows that there is field for this journal club. Okay, and you had a patient that was COVID positive, so obviously you didn't want to intubate him and take him to theatre. Great, so I'll hand back over to Daphne or Andrew.
Thank you very much, Harris. And just following on from what Harris was saying as well, and just a general opinion poll at this point to see what you would actually do. Would you conservatively manage Harris's patient, or would you want them to have an appendectomy? So if you could just write that in the comments box. And Harris and Andrew, because I can't see the comments box, if everyone's replied, just let me know.
Okay, I'll give you a summary. So what do you want to know from me, Daphne?
That everyone.
Okay, we're getting conservative, admit and observe, plus COVID swab.
So there's a general leaning towards conservative management compared to surgical, from what I can tell. So what we're going to do now is it's your turn to do a little bit of the appraisal now. So Andrew's going to send a link where if you click on the Google link, then you'll be allocated a number 1 or 2. If you're number 1, we'd like you to focus on the internal validity of the paper that was chosen to be appraised, and then number 2, so group number 2, looking specifically at the results. So our aim is that everyone reads through the abstract, and for the internal validity group, looks through the methods and the summary of the studies, and then the results group focusing on the results. And then we'll come together to talk about each aspect and see what we think as a group about this particular paper and what we will do in the future. So this is just a summary of what we mean by validity. So we're going to be looking specifically at the study design. Do you think that there were any biases that could have been introduced through the way they've actually carried out the systematic review and meta-analysis? And then the results section looking at how big the effect size was and how precise it was. So then we'll talk together about whether or not this is applicable to our population. And we're going to give 20 minutes from now, so that will be at around just before 1:45, where we will have a discussion about what you think of the paper itself.
Please ignore the spurious video link that's left over from last week. And if you can't get the Dropbox link, send me your email address and I will send it.
Perfect. And I'm just going to put on our other slides just while you're working on that.
Ooh, and we've had mixed feedback on music backing tracks, so you can also tell us in the chat whether you want us to play music or not, if you care.
And we're about there, done. Please let us know, by the way, if you have any questions, just write it into the chat. Oh, Andrew's just mentioned that as well. Any questions, we'll be looking through the chat box during this 20 minutes. Hi, Jyoti. No one's speaking at the moment. It's just that we're, if you've just joined now, if you can, Andrew Mercado has sent a link to the Dropbox where the paper is. If you can assess the validity of the paper. Thank you. Hi, Niall. No sound at the moment. It's just that people are individually working through the paper. Have you got access to the paper? If not, it is Andrew McCardle has sent a Dropbox link that's a bit further up in the chat.
I'm doing it now. I'm doing it privately.
And also, we will be coming back together in 6 minutes. Of course, just doing it now. Okay, everybody, thank you. We're just going to come back together now and appraise the meta-analysis. So Harris, if I can get you to start that, and I'll bring up the CASP tool.
Sure. Thank you everyone for going through that. I hope you found it a fascinating read. So Daphne is now sharing the CASP checklist on the shared screen. I'm hoping that most of you had a look through it. So can we start from the first question? We always start off looking at papers, as many of you know by now, by looking at validity. So obviously, if a paper cannot be proven to be valid, then there's not much point carrying on and analysing its results. So those of you that were randomised by Andrew in the first group to look at validity, or those of you that had extra time to look through those questions, can we start working together through the first question? Did the review address a clearly focused question? And the CASP checklist is giving you some hints. So do you think the population they studied is a relevant one to our PICO? And was it representative enough? What did people think?
And you are welcome to unmute your microphone and speak, or you can type.
Absolutely. So in terms of ages, their disease severity, their presentation, was it representative of our population, and did they include an appropriate range of presentations and ages? It usually takes people a few seconds to warm up and start answering, but just to, yes, Noella says yes. Is there yes? They didn't specify how children were defined with regard to age. Right, so perhaps I should have specified that there is a useful chart of the studies they included, table 1, which is in page 769 of the paper, that actually shows you the characteristics of the studies. And in that table, the last column is on patients. So you can see that for the RCT, which was a pilot trial actually by Svensson et al., they had ages between 5 and 15 years. The next study, which was an RCT again, 7 to 17 years. Next cohort, observational 6 to 17. So all of the studies seem to avoid including the infants or the toddlers, apart from one that used age 3 to 15. So you get a lot of answers from looking at that table of the characteristics.
Harris, I was just...
Niall says they didn't specify how children were defined in the paper, but obviously you can see what they picked out ultimately.
I was also going to say that in a systematic review, sometimes it narrows it down too much if you actually say children aged 5 to 10, for example, because then you miss a lot of the papers that may include it but may not have actually specified. So sometimes keeping it broad in a systematic review is good.
Yeah. But Niall's point is that actually they should have pre-specified, and if they wanted to say, well, they'd accept papers who had a sort of overlapping and maybe went up to 20 or 21, they should have specified.
Absolutely, that's a very good point. And sometimes the only way to find out is by looking at the protocol. But yes, that's a very good point. They should have mentioned that. So everyone agrees that the population of the study was pretty focused and that they looked at appendicitis? And do you think in terms of the types of presentation they included, that is relevant to our question? Just to remind you, we wanted to only look at suspected uncomplicated appendicitis. And again, you'll find that answer in that table. And then in terms of the intervention as well, Daphne is kindly filling in the PICO for us. are we all happy as to whether the question was focused and whether the population and the intervention used was relevant? Just a point to make about intervention. Did anyone spot what kind of conservative management most of these studies used? I mean, did they use watch and wait approach, oral antibiotics, IV antibiotics? Noella says they looked at appendicitis secondary to fecal. Yes, they actually included studies with and without fecalifs, which is a difference between this paper and the one in the archives where they excluded fecalifs. Our rationale for including them was that often they present in the same way. So it's a more pragmatic way of looking at things. When you see a child in ED, you don't necessarily know if they've got a fecalif. So we decided to go with the review that included those. Harry says IV antibiotics. Yes, so most studies treated children with IV antibiotics, or they gave them a shot of IVs or a day of IVs and then orals. Okay, so moving on to the next question of this section, did the authors look for the right type of papers? And as we've discussed at the beginning, it's a treatment question. You would expect them to focus on randomized studies. As Andrew pointed out above, they confusingly use the abbreviation RCS to talk about cohorts. Cohorts are another way of looking at interventions when you want to see if there is enough grounds to design an RCT. So what do people think? Did they look at papers that addressed the question? That's, I guess Harry's point comes into this, that they didn't pre-specify ages, an appropriate study design. So again, if you look at table 1 with the included studies, that's going to give you the answer. And you can see from that table, I don't know if Daphne has the possibility of bringing it up, otherwise I'll share my screen. Let me just rotate.
I can bring it up. I'll just
Okay, thank you. Just the table 1. So you can get a lot of information from looking at the figures, the tables, and sometimes that's where the answers of these appraisal questions are found rather than in the narrative. So we've got a few views. They excluded non-English studies, that's correct, and they did. And as we know, that's not the best practice, even though it's very often done, because that's a practical and pragmatic way. RCTs, RCS, and retrospective studies, prospective cohort studies, a wide range, although 9 in numbers. Yes, so Daphne is kindly showing you the types of the studies. So one of them was randomized pilot, the other was a proper RCT, and the rest were observational. Yes, so of course, those were the studies that they found. Those were the studies that have been done. So do we agree that considering the clinical question, they've done the best they could considering what was available in the literature? Yeah. If you have any objections, feel free to share with us. The evidence is not always perfect, but it's about whether based on the questions you have done the best you could. Okay, so shall we move on to the results? Oh no, sorry. Yep. So did the reviews authors do enough to assess quality of the included studies? And in the hints, you can see how you can consider this question. So this is where we are looking for risk of bias of different sorts. And yes, non-English, yes, that's correct. Good point. Okay, so if this particular systematic systematic review, just like you see in Cochrane reviews, in the longer reviews, actually has a table that has the color-coded Cochrane system for assessing bias in included studies. And that's your color coding kind of traffic light system that you can see in figure 2 in page 772. And you can see how they've categorized the risk of bias. So what do people think? There's many greens, but there's also reds, and we don't really like reds. But sometimes you can't really prevent. They probably use Cochrane, yes. Yes, they used this.
They also used a tool called Miners, which I wasn't familiar with, but it's one of several thousand different tools for assessing observational studies. So there are lots of them available. I have downloaded it to have a look at it. And that was for the majority of studies which were non-randomized cohorts, because the Cochrane risk of bias tool is only for the randomized stuff.
Yes, so we generally use GRADE. I wonder if the paper they were submitting for used that kind of assessment tool, and that's why. So high performance bias. Interestingly, they have reds in the blinding, and that's very common in studies where to blind participants would be either not practical or unethical. So to really blind participants and personnel, staff performing the two treatments, you would need to take children to theatre and pretend that you're doing an operation on them. And then for the others, deliver a placebo medication. So you can easily see why that wasn't done in this study. But as the authors rightly point out, they could have blinded for the outcome assessment. So the person assessing whether there's been complications, length of stay, and all of that could have been blinded. And it looks like it was done in one of the RCTs, the Hall et al. 2017 study, but not the other one. But the authors of the systematic review did look into that. So this is what we are assessing at this stage. Okay, and if the results of the review have been combined, was it reasonable to do so? What do people think? Were the results similar from study to study? How different were the studies? So someone has already mentioned that some studies particularly looked at fecalids. Reasons for any variations in results discussed. So because most of the studies actually used treatment of intravenous antibiotics, they've done a combined pooling of the results. Heterogeneity in the one-year outcomes. Yes, there was heterogeneity. And we'll discuss that when we move on to results. So I think it's fair to say that there's been heterogeneity in the studies, but have they made an attempt to do some subgroup analysis? And to address these heterogeneous outcomes? So for fecalids, there is actually a separate forest plot, which is, I think, the last one. Yes, where they only looked at those patients. And then, as expected, Harry pointed out very correctly that in the 1 year there is heterogeneity, and generally when we are looking, the longer the duration of outcomes we're looking at, the more, I guess, grounds it leaves for these kinds of heterogeneous results. We will have a look at the forest plots in a second. We will go into that, but very good point. And someone is saying Bacher is a significant outlier with a much larger sample group. So not sure about including it in the combined data in figure 4. Okay, as I said, we'll come to results. Let me just have a look which figure 4. Oh yes, so we are looking at the 1 year. That's absolutely correct. So there is some heterogeneity, but it's about whether they've done whatever they could to address it as an issue, and whether they've done something then to do some subgroup analysis. So we have decided that it's a yes because they have commented on those heterogeneous.
Well, I would add another concern I have is that you've got 2 of the studies which are randomised, and you've got 2 of them in which they're non-randomised. And if you go and look at the abstracts for them, they're all non-randomised on the basis of parental choice. So you can question whether they're really similar studies.
Yeah, so significant selection bias. And I was actually surprised, based on what Andrew has just said, that they don't have a separate forest plot just for the randomized studies and a separate one for the observational, but they have just pulled them together. And I guess this is a good point to move on to results and discuss some of these points that have been raised. So what are the overall results of the review? Do you think, by looking at the results, we've decided, for the interest of time, for now to focus on figure 3, which is looking at 1 month outcomes. We feel that 1 year is a bit too long. We usually want to know how successful the management of appendicitis is. We're talking about an acute presentation. So we decided to focus on 1 month, and then the figure 5, which is looking at incidence rate of complications. And then if we have time, we can just very briefly touch on figure 7. So from figure 3, I'm guessing many of you would have looked at forest plots by now. Only consider 6 out of the 9 studies. I think that's because they excluded.
I think it may be to do with outcome availability as well. So not every study will report every outcome.
Yes. So just looking at those results, so we've got a pooled overall effect size, which is reported as an odds ratio in this study. And because it's a ratio, as most of you know, the line of no effect sits at 1. So you can see that whereas most of the studies, their odds ratio is on one side of the line of no effect. However, their confidence intervals are crossing the line of no effect. When you pull them together, though, your diamond shape is all on one side, not crossing the line of no effect. So that's the power of meta-analysis, as most of you know. So we've got an odds ratio of 0.122 with a significant confidence interval that's not crossing 1. What do people think that means? Just very quickly.
I'm just really surprised how it totally goes against what they write in the abstract and in the conclusion, because they say very clearly in the abstract there's no significant difference, and then they clearly show by their analysis a significant difference. I'm amazed that that has been published.
Yeah. So Andrew, you're absolutely right. I read it and reread it to make sure it wasn't a typo, but I think that falls into the last question of making the clinical inference. And I wonder if this is what the authors meant, because at some point they talk about if you could avoid an unnecessary operation with a risk of needing to do it at a later stage in a couple of days, would you opt for that? So I wonder if they reach that conclusion making a clinical inference. But yes, it's 12 better chance of it, 12%.
Yeah, so Harry, you said 12%. I'm wondering if that's something you've extracted from the 0.12 odds ratio. Because the way I would interpret that's actually an odds ratio of success for conservative management versus appendectomy. So that's actually saying your odds of success if you had conservative treatment were 12% of the odds of success if you had an appendicectomy. So to me, I find that I can't see how that's saying better outcome, actually. To me, that seems like a worse outcome. And if you just look at the raw numbers in the results, they present that the success rate was 99% in the appendectomy group and 90% in the conservative management group. So it stands to reason that if the analysis came out in favour of one side, it would be appendectomy.
Yes, exactly. And if you guys out of interest want to look at the archives paper, which is a bit older, they, in some journals, when authors report forest plots, they make it a bit more reader friendly, and they say control favors intervention. So that would be a bit clearer on the forest plot. So on your forest plot where your diamond shape lies, it should say favors comparison, so favors operative management.
If we're learning anything from this paper, we're learning why it's important to read the paper and not just the abstract.
Absolutely, and the conclusions, yes. So I guess the question is it very bad, Neil? So yes, one is worse than the other, but how bad so is up to us to decide, and that's why the third section of the critical appraisal is always so important and should never be skipped, because that's why you combine the statistical with the clinical inference. But yes, this paper suggests that there is a better outcome at 1 month for surgical management. And what we mean by that is not complications at this stage. It could just mean that some children didn't get better and they ended up having the surgery anyway. So, and how precise are the results? This is where we look at confidence interval as always, and we can see from the forest plot figure 3 that a lot of the confidence intervals are overlapping. Yeah,
I think Harry had mentioned that as well earlier, just said that there were good overlaps of the confidence intervals.
Perfect, yes. And we can see that the overall combined confidence interval is reasonably tight, so it's not very close.
Some of them are, I mean, gosh, the one that makes me laugh is figure 4, which is for success rate at 1 year, and despite all of the studies and all of the numbers, and I struggle to understand this, it must be to do with Backer, they end up with a confidence interval that goes anywhere from over a 99% reduction in the odds of success to a 2% reduction in the odds of success, which is an extraordinarily wide confidence interval.
Yeah, also, just since you've mentioned that, even though we said we weren't focusing on the 1 year, but that's interesting learning point, you can see that most of the confidence intervals are overlapping, and then you have 2 outliers. Interestingly, one is on the extreme left and another one is on the right. The one on the right is actually the randomized control trial. And you can see from the I-square, the measure of heterogeneity, you've got very high heterogeneity in this study. Just for a refresher, that I-square can be between 0 and 100. Obviously, anything close to 100 is really bad. It shows you almost definitive heterogeneity. Depends on the author. Some authors say anything up to 25% is acceptable, 25 to sorts of 50, 60 sorts of equivocal, and anything above that is high. So I'm surprised the authors even bothered to show that forest plot rather than just break it down into subgroup, but they did, which is good for us for learning purposes.
Which is just going back to what Niall had said at the beginning about the Baccio study, which I think it was what he was referring to.
Yes, someone mentioned, I couldn't remember the name. So if you were doing a meta-analysis, I think you would want to exclude it at this stage and then see how your I-square changed after that. And do people want to mention anything about fixed effects and random effects? We really don't have much time.
Probably not, because we're out of time.
We are actually, yes, we are over time. So that's maybe in discussion for a different date. And then you can use the rest of the forest plots to play and have a think yourselves about what you see, what the authors have done, and what conclusions you can draw from them. Or you can bring this paper or similar ones in your departments for for discussion and play with the statistics. We should never skip the last section of critical appraisal, so let's just very quickly all consider those. Will the results help locally? Can they be applied to your local population? So remember, we were talking about children being managed conservatively, and in our department that meant being given oral antibiotics. In many cases, they were given a shot of IVs and then switched to orals.
I think this is just Niall had mentioned, I don't think it's relevant, the 1 month. So if you could elaborate on that, because that's technically an applicability question for us. Why do you not think it's relevant, Niall?
Sorry, I was just typing, but that's just taking too long. So just having done a couple of peds surgery jobs, I've both seen patients coming back with complications with significant complications after 1 month, and that those patients actually representing, although smaller numbers, significant amounts perhaps of the clinical workload and morbidity seen in the department, personally from a peds surgical perspective, because they come back when they recur, they are very unwell, and you can get multiple recurrences, multiple operations and abscesses. So that was one of my main caveats on the 1 month front. It also doesn't give you much idea of from what I could see, quick look of the breakdown underneath 1 month. So you having recurrences sometimes within 3-4 days, or is it, are you getting primarily 2-3 weeks? And again, having worked on these with these patients, those can be quite different clinical entities. And so I'd want to be much more confident about that, what that kind of breakdown of recurrence was like before I started applying that to my patients. I will mute again.
Thank you very much for sharing and for talking to us. So that's a good point, and often, as we do it more and more, maybe what we see in practice may differ from these patients, because these studies were done a few years ago. So interestingly, we didn't have time to look at the forest plot for complications, but there was no significant difference when it comes to complications between the two groups. But yes, if what we are seeing in practice is very different, then there is perhaps scope for more studies. And in fact, there are some RCTs, you can find their protocols online, that are currently recruiting, and they are ongoing. Obviously, we couldn't include them because they haven't been published. So watch out for those results, because they may give us more conclusive results. And hopefully those ones will have lower risk of bias, and they would have looked at more relevant to us timeframes. So we've put can't tell, so it depends. The pandemic has given us the opportunity to explore all of these things. It would be useful to collect observational data from our departments, the ones that have been shared, and all of them together, and see what we have on an observational level. And where all important outcomes.
Just so, yes, because of timing, we might not be able to consider all of the final questions in detail.
Yeah.
So it might be worth seeing, if just seeing based on what people have seen so far, does it change your views at all on the safety or otherwise of appendectomy, given the challenges in the evidence, or are you left with just, well, based on my own experience?
A little straw poll. So now, just before we finish, a lot of people said conservative management at the beginning. Do you still think that you would go for conservative management, just based on the paper that we've just appraised? I think it sounds conservative still. Probably yes. So we're sticking to conservative still. So I'm
I
glad.
have to be honest, I don't think I wouldn't let this paper influence my view at all. So I'd be left on the sort of, well, just going with whatever people think is best, because all of the errors we've identified in how they've presented the data means I'm not sure I even trust the analysis. So I'd want to see a different review, I think.
I fully agree, and I was just worried that when no one was replying, but it confused everybody so much that we weren't getting results.
Yeah,
so that's good.
and I
Okay.
want to see the studies that are currently running. So if anything, it triggered my curiosity, and obviously a lot of specialists in the field didn't think that these papers gave them an answer, which is why hopefully more robust studies are currently being run.
Perfect. So watch this space.
Yes.
I think this is, sorry, we've run a bit over time. Thank you very much for everybody for all the input that you've put in today. We'd always value your feedback, and we've got the link there on the slides. So if just a couple of minutes just to get your feedback would be great. And if anyone is interested in doing any of the further case scenario presentations, we would be very happy for you to contact us, which is either I think you've got Andrew's email on the LSB website, so if you could email one of us, we'd be very happy to coordinate that. Thank you very much.
Shared, oh, sorry, I didn't share it to everyone. Let me just share it to everyone. I'm just sharing the learning pack for the week because it also includes an activity on research that you can link to your portfolios. We've included an activity for you guys to learn or teach your colleagues on PERUCI, which is the Pediatric Emergency Medicine Research Network, and a particular activity on research without any prior consent. So if any of you have an interest in the field, have a look and use it with your colleagues in the workplace.
Thank you very much.
At 2:30, just a reminder, there is a talk on the minor MSK PEM presentations that had to be rescheduled. Some people had asked for it to be rescheduled, so I may or may not see some of you in 15 minutes. Thank you.
Thank you very much. We've just left some useful resources there just to get some further learning from there. But thank you very much for joining us, and hope you have a lovely weekend. Bye, everybody.